Hi everyone, my name is Shomron Ben-Horin. I'm the chief of the Gastroenterology department in Sheba Medical Center in Israel. And it's a pleasure to be here with you and talk to you on behalf of the IBD Club on capsule endoscopy as a monitoring tool for Crohn disease, and is it bringing the future near to us? So as you are probably all aware, mucosal healing, the healing of the lining of the gut, is an important attribute of our aims in treatment of Crohn disease. In fact, in the Scandinavian cohort study shown on the left-hand side, but replicating several other studies, it was shown that patients who achieve mucosal healing with Crohn disease have a much reduced risk of surgery and other adverse events during later on a course of disease. Indeed, later on in the clinical trial, a seminal trial called Calm study, it was shown that managing our Crohn disease patient based on CRP and calprotectin biomarkers level as indices of inflammation, as opposed to managing them only by symptoms, was associated with better outcomes down the road, and this was significantly so. Nevertheless, as you can see on the figure to the right, even this interventional strategy based on biomarkers still failed to achieve the desired outcome in over 50% of patients. And the question is, can we do better? So for that, I think we need to visualize the small bowel and guide our therapy upon this visualization. And one important tool for doing that is ingestible capsule endoscopy. This is an ingestible small camera that, after being swallowed, traverses the entire small bowel and captures video pictures of the entire small bowel. Importantly for patient, it does not require bowel preparation for this study. In a study when we looked at patients who were having a Crohn disease but were in remission regardless of the therapy they received, we were surprised to find that actually more than 80% of this patient in clinical remission still had on capsule endoscopy evidence of active inflammation in the small bowel, which in some patients were actually moderate or even severe in activity. As you can see, some patients with ulceration or even spontaneous bleeding in the small picture insets. Even when we looked only at patients with clinical and biomarker remission with normal CRP and mildly elevated or normal calprotectin, still 60% of patients had evidence of active inflammation on capsule endoscopy, suggesting what we are seeing without capsule endoscopy is only the tip of the iceberg. We translated these findings into a prospective study whereby we followed Crohn disease patients in remission by calprotectin every 3 months and capsule endoscopy every 6 months for 24 to 36 months. 61 patients were recruited, and each one of them underwent capsule endoscopy at time 0, 6 months, 12 months, 18 months, and so on and so forth. And for each patient, we would then receive his or her results of calprotectin every 3 months, as well as capsule endoscopy every 6 months, as you can see in the figure. Overall, the results indicated that the Lewis score, the inflammatory score obtained by capsule endoscopy view of the small bowel, predicted very well up to 24 months before a clinical flare, so was very predictive of the clinical outcomes thereafter. Calprotectin, as you can see in the figure, was predictive of such a flare only about 3 months before it actually happened. So capsule endoscopy was much better in predicting flares 24 months before for the long-term risk of flare as opposed to calprotectin. You may ask yourself, what is the safety of capsule endoscopy in patients with Crohn disease? And one such concern is whether it might be retained in the small bowel in patients with strictures. So what we and others have found that using the patency capsule, this is a dissolvable capsule that is swallowed before the video capsule to ascertain the patency of the small bowel. This was very accurate in precluding the tests, the video capsule from patient at risk for retainment. And indeed, over 24 months of 231 video capsule we administered to our patient, there was no retention of any of those capsules after a passage of patency capsule, even when MRE, as an MRE figure in this patient of mine, was showing strictures or narrowing of the lumen. But a patency capsule that passed through this narrowing was ensuring that also the video capsule will pass. These results were largely replicated, although by smaller and shorter duration studies, but both those studies showed similar results whereby video capsule endoscopy findings were predictive of 1 year risk of clinical exacerbation and were doing that better than calprotectin. Interestingly, a study from China has also showed another use for video capsule, whereby a patient who underwent surgery for Crohn's disease and had ileocolonoscopy 6 months later were compared to patients who underwent ileocolonoscopy and capsule endoscopy 6 months after surgery. And it was found that patients who underwent both modalities, also the capsule endoscopy, had more inflammation being detected, more intensification of therapy, and more importantly, they had much less clinical flares and clinical exacerbation of disease with this strategy of employing capsule endoscopy and ileocolonoscopy rather than ileocolonoscopy alone to stratify the risk of the patient to flare. This may be partly due to the fact that we know that capsule endoscopy detects proximal small bowel inflammation better than MRE and other modalities, certainly ileocolonoscopy that cannot reach those areas. So probably some of those exacerbations are due to proximal disease that is detected only by capsule endoscopy. And I think very important for our patients is also the fact that capsule endoscopy is very patient-friendly. In several studies, it was shown that like intestinal ultrasound, patients prefer capsule endoscopy even over what we usually think of as a non-invasive MRE. And also the near future is becoming exciting for our patients with capsule endoscopy. I think there is now evidence that capsule endoscopy can be performed at home, and this will be incorporated more and more in the near future, as is done currently in the UK in a large clinical trial. And we have also published our initial attempts of using deep learning AI, artificial intelligence tools to enable automated detection of Crohn's ulcers and interpretation of capsule finding, hopefully soon obviating the need for physician reading of the video films of the capsule. So my message is that capsule endoscopy enables direct viewing of the entire small bowel mucosa. After performing of a patency capsule, this ensures the safety of the video capsule even in patients with Crohn's disease. And the capsule is superior to calprotectin in predicting the long-term outcomes of Crohn's disease patient, and is also superior to MRE in terms of patient acceptance and tolerability. These are important features because without patient acceptance, no monitoring is useful. If it's not performed by the patient, if they're not accepting it, certainly it will not be useful. And we can only think about patients doing blood pressure monitoring at home or glucometers for the diabetes to show us how monitoring a friendly one that can be done at home is important, and capsule progresses us toward that future. In Crohn's disease in our clinical practice, we now routinely use capsule endoscopy to monitor mucosal healing in our treated patient, as well as in some patients with unclear symptoms, whereby we use capsule endoscopy to ascertain whether indeed this inflammation is a source of these symptoms or is it not. So with that, I would like to thank you very much for your attention, and I hope to see you again very soon on another IBD Club broadcast such as this. Bye-bye.